Записывается?
Нет.
Нет.
Такой звук.
Так, начали. И... Так, а здесь есть это, да? А, чтобы не было, да?
Да. И стрелочку.
Так, а как увидеть окружающую обстановку?
Вот так.
Вот так. Хорошо, спасибо. Well, good afternoon, dear colleagues. Now we'll start with our lecture. We'll discuss today cardiac arrhythmias and blockades. You see here the title of this lecture, Disturbances of Cardiac Rhythm, Disturbances of Cardiac Conduction. So, come on. You see here, what about the general approach to the patient having some rhythm abnormalities? You see, it's the rather common problem with very wide range of prognosis, which varies from benign to serious. For example, some premature beats, supraventricular or ventricular, may provide not so significant problem, but serious like ventricular tachycardia or moreover ventricular fibrillation. Sure, we have to make the prompt decision for any management, any treatment. In many cases, cardiac arrhythmias lead to some rather significant patient anxiety, some hesitation, and so on. And in some particular situations, the arrhythmias may produce the significant risk of sudden cardiac death, stroke, and so on. I think that it's always potential manifestations like palpitations, dizziness, presyncope, and at last syncope, and associated symptoms sure depends on the shortness of breath, may accompany with chest pain, chest pressure, sometimes with nausea, vomiting, paleness, diaphoresis. But remember that practically in all cases of arrhythmias or blockades, this symptomatics depends on underlying disease. So we must evaluate the history of the disease and perform physical examination. So the prior history of cardiac disease may play a significant role for your further management. And sure, we must take into account the family history, especially the history of sudden death among the closest relatives of the patient. Diagnostic tools. Sure, ECG is number one. For it, what means Holter monitoring? In many cases, we have only plain ECG. Remember, we register it in few minutes. Sometimes it is insufficiently to evaluate some not so frequent arrhythmias. And Holter monitoring provides the long-term registration of the ECG. The duration of this registration varies from 24 hours, may be prolonged up to 48, 72. Sure, the patient must resist for such investigation, sometimes up to 7 days with the hot battery exchange. Sure, it is not so comfortable for the patient, not so convenient for the patient, But in some cases, it is essential to provide the extra long recording of the ECG. We use for such purposes so-called event recorders. In nowadays, these event recorders are not wearable, but they are implanted, moreover, injected. We'll discuss it a little bit later. In some cases, we need to perform the exercise stress test to provoke, to reveal some arrhythmias. Echocardiography, we need to get the information about the underlying disease. And at last, electrophysiological study, it provides the knowledge about some fine mechanisms of the arrhythmias, and moreover, it is the preparation for interventional treatment of the cardiac rhythm abnormalities. You see here, it's the ECG. I think you understand this ECG looks quite normal. It is not a problem. And when we use Holter monitoring, on this picture you see the patient's body with the electrodes attached, with the monitor also attached to the body, or maybe some belts, pockets, and so on. Well, and it is, you see, useful in patients with daily or nearly daily events. And sure, it characterizes heart rate and arrhythmia over entire day. It is obvious that it is not useful in patients with infrequent arrhythmias, with rare arrhythmias. And for such purposes, we use event recorder. You see here the strip of the ECG when we catched the episode of looks like ventricular tachycardia, but it is not ventricular tachycardia. It's then episode of atrial fibrillation with the temporary left bundle branch block. But this situation is not so pleasant. And how to reveal, you see here, uh, these event recorders work continuously, and in the oldest devices, patient activated device to capture event, but the but the advanced devices may be implanted. You look it on the X-ray film. Implanted, or moreover, the newest devices can be injected, and these devices, the common name is Reveal. Reveal can record all the heart electrical activity during 1 year, and sometimes we can pull the information from these devices to get the ECG picture, and to compare it with the clinical data and so on. Treadmill. At first, it evaluates cardiac ischemia. Sometimes it is able to assess exercise-induced arrhythmias, but it has limited value in patients whose arrhythmias are not reproducibly initiated with exercise. And echocardiography. So we have the special particular lecture for echocardiography, but in few words, it's the transthoracic two-dimensional echocardiography or transesophageal echocardiography. It is sure useful to define overall structure and function of the heart. It is very important to evaluate right ventricular function when the right ventricular dysplasia exists or suspected, and also important in assessment of any cardiac problem, including the valves involvement, valvular dysfunction, pump contractility dysfunction, and so on. Electrophysiological study. So it can uncover causes of syncope. It helps to define mechanisms of spontaneous tachycardias. Patients also may undergo electrophysiological study-guided drug testing, and it also may determine whether a particular drug can suppress an inducible arrhythmia. And it is crucial to map arrhythmia for certain types of non-pharmacological therapy, for example, radiofrequency catheter ablation. And on this picture, you see here how we perform the general approach to electrophysiological study. Why we need to know the main mechanisms of arrhythmias? Because we have to understand the general mechanisms of action of any antiarrhythmic drugs or non-pharmacological intervention. So, you see here, it's so-called reentry. What is the reentry? It is the circulation of electrical impulse on the some separate part of the myocardium with one-sided blockage of the entrance and outlet of the impulse. We classify it like conduction mechanism and impulse formation mechanism. It is the increased automaticity and triggered action. So, reentry mechanism is essential for paroxysmal arrhythmias, increased automaticity for premature beats, the same for triggered action. But in general, all these main mechanisms may may give the part to the general mechanism of any arrhythmias. So, general principles of arrhythmias management. You see here, you must take into account that many arrhythmias are benign and don't demand special treatment. So don't be hurry to make such a decision to treat, to insist on some treatment. Think a little, because you have to understand some conditions which promote or contribute to occurrence of rhythm abnormalities. You know these conditions well, like smoking, alcohol, stress. So you have a chance to correct this problem. And whenever possible, use smaller doses and amount of medications. And to provide an effective preventive treatment of potential life-threatening arrhythmias. So be strong for such a decision if you think that some type of arrhythmias like the recurrent ventricular tachycardia or high-grade ventricular premature beats, you have to provide the effective preventive antiarrhythmic treatment for such events. And please remember that nowadays it's the we see the quick progression, quick evolvement of the newest method of the treatment, invasive treatment for some types of arrhythmias, and we must take into account that the usage of these invasive treatment methods is very useful and very resultive. So, when we consider the medications for the treatment of the uh, arrhythmias, we must take into account this classification of antiarrhythmic drugs by Vaughan-Williams and Singh. It divides in four classes. Class 1, we name it like membrane stabilizing drugs or fast sodium channel blockers. This class 1 divides in three subgroups like 1A, 1B, 1C. 1A is presented by quinidine, procainamide, disopyramide. 1B, lidocaine, mexiletine. 1C, flecainide, propafenone. The field of usage of these medications, class 1A, usually for treatment of ventricular arrhythmias, partially for supraventricular, 1B exceptionally for ventricular arrhythmias, and class 1C, the both for ventricular and supraventricular arrhythmias. Class 2, antisympathetic drugs, but better to name this class like beta blockers. Beta blockers are useful predominantly for treatment of supraventricular arrhythmias. Class 3, drugs that prolong action potential duration. Better to say, this class is presented by amiodarone and sotalol. These drugs are used for treatment both of ventricular and supraventricular arrhythmias for atrial fibrillation. And class 4 is presented by calcium channel antagonists. We usually use just a few medications like verapamil and diltiazem, practically especially for the treatment of supraventricular arrhythmias. And here is the more contemporary classification. We name it like Sicilian gambit. Sicilian gambit, why Sicilian? Because this classification was accepted during the meeting of arrhythmologists on the Sicilia island. It is an approach to critical components and vulnerable parameters of cardiac arrhythmias. And you see here practically all the mentioned antiarrhythmic drugs are already here, including the drugs we haven't discussed, like atropine, adenosine, digoxin. We can add here the potassium. And you see here, atropine we use to treat some bradycardias. Adenosine we use to prompt treatment, intensive treatment of supraventricular arrhythmias. And the oldest drug among all of them is digoxin cardiac glycoside. We use it usually for heart rate control, especially in atrial fibrillation. And we repeat here, these are the sites of action of antiarrhythmic drugs like class 1 and class 3 for treatment of supraventricular atrial arrhythmias. The drugs which influence on EV node class 2, class 4, digoxin, adenosine, accessory pathway associated with the presence of Wolff-Parkinson-White syndrome class 1, class 3, and at last ventricular arrhythmias class 1, class 3. You see here the Primache beat. This premature beat has narrow QRS wave, but with a different P wave, it is presented as supraventricular premature beat, supraventricular extrasystole. Not so significant problem. It is rather frequent, rather common, in many cases asymptomatic without any prognostic significance. How to approach for the treatment? Please give good advice to avoid some inciting factors like caffeine, alcohol, exercise, and so on, mental stress. Reassurance, please explain the patients that it isn't the serious problem. And in some cases, beta blockers are useful, but only if symptoms are intolerable. It's an atrial fibrillation, very nice picture. It's the very serious problem. Very serious. You see here the epidemiology of atrial fibrillation with the rise of the prevalence, percentage of prevalence, according to the aging, and it exceeds 10% in the population of the patient over 17. It usually depends on the presence of the multiple recirculating wavefronts. In this situation, when we consider an approach with active invasive treatment, we must catch these micro-reentry circuits with the multiple lines of ablation. It looks like not so easy task. But sometimes it may give the positive result, and in very rare cases, atrial fibrillation depends on the presence of a single focus. And sure, in this case, we can perform an ablation to eliminate this atrial fibrillation at all. Well, I have to return this slide, how to do it. So, we see here the classification of atrial fibrillation. So we distinguish such positions like initial event of firstly detected episode, paroxysmal, persistent, and at last permanent or accepted atrial fibrillation. Initial event, and it can be symptomatic or asymptomatic when it is a discovery, we firstly detected it. And when onset unknown, first detected, sure, we must make a decision what to do with this. Paroxysmal. Usually it is self-limited up to 7 days. No, usually self-limited in few hours. Few hours, most often before 48 hours. And what is the main difference of paroxysmal between paroxysmal and persistent? Persistent is not self-terminating, not self-limited, and it lasts for the time exceeding 7 days of prior cardioversion, and you see it needs the doctor's intervention, the usage of some medications or maybe electrical cardioversion. And at last, permanent or accepted atrial fibrillation, it is not terminated but relapsed, and at last no cardioversion attempts were performed. The next, we consider two strategies for the management of atrial fibrillation. The first is so-called rate control, when we accept the atrial fibrillation, maintain it. We control the ventricular rate using digoxin, beta blockers, calcium channel antagonist, amiodarone as well. And we must provide anticoagulation. Remember, please, when the atria don't contract, perform some fibrillation. What means fibrillation? It means the inability to contract, and in this situation, the probability of thrombi formation in the cavities of atria, predominantly in the left atria, this ability is very high, this probability is very high. So we must provide good, strong anticoagulation. And another strategy, we name it like rhythm control. When we restore the sinus rhythm and maintain, try to support, try to maintain it. So remember, please, two strategies, rate control and rhythm control. How we achieve the rhythm control? We perform cardioversion, we restore the sinus rhythm. The cardioversion may be pharmacological. Usually we use amiodarone, the loading dosage of amiodarone, and electrical cardioversion, direct current, now alternate current, so biphasic impulse. And then we have to maintain, support the sinus rhythm with the usage of antiarrhythmic medications using the type 1A, 1C, 3, but the third class, amiodarone, sometimes sotalol, are preferable for such purposes. And in any case of atrial fibrillation, moreover, when we already achieved the sinus rhythm, we must provide permanent anticoagulation. The old anticoagulation drug is warfarin. In other words, vitamin K antagonist. But warfarin, usage of warfarin, it needs to maintain the laboratory control of international normalized ratio, not to exceed the level of anticoagulation and at last get the complications like bleeding. Nowadays, we use the modern drugs like factor 10A inhibitors like rivaroxaban, apixaban, and not so popular but also useful direct thrombin inhibitor, it is dabigatran. What are the contraindications for sinus rhythm restoration in atrial fibrillation? Well, these are non-corrected mitral valve disease, especially mitral valve stenosis, non-corrected tirotoxicosis, significant left atrium enlargement, so the dimension exceeding 50 millimeters based on the echocardiography data, and at last cardiomegaly in general. So it also, it is in general it is not contraindication, but it means a poor prognosis of the rhythm restoration, and moreover the sinus rhythm support for obviously long time. To avoid the problem associated with the thrombi presence in the arteria during the cardioversion, we use transesophageal echocardiography. You see here the heart, yes, the heart. For chambers, the patient has atrial fibrillation, and how the investigation is performed. We have such a mem that it is an non-invasive procedure for doctor and invasive for patient. And now you see here, normal left ventricular appendage here, not left atrial appendage, without any thrombi, with good blood flow velocity in this left atrial appendage. So it means the absence of contraindication to sinus rhythm restoration with cardioversion. And another pattern, you see here the presence of the thrombus in the left atrial appendage. I explain it's the body of the left atrium appendage, mitral valve, left ventricle. And you see here the very, very poor velocity in this left atrial appendage. It means that patients need the anticoagulation as a preparation for sinus rhythm restoration in this situation. Well, how to control ventricular rate? So we already discussed it in brief. To control symptoms, to avoid tachycardia-related cardiomyopathy. Remember, it's in the case when we accepted atrial fibrillation. We have to avoid so-called tachycardia-related cardiomyopathy. We use digoxin, beta blockers, calcium channel blockers, and class 3 medications like amiodarone, sotalol. And invasive approach, sometimes we need to perform atrioventricular nodal ablation, total ablation with further permanent pacemaker, and in some cases even nodal modification. Now I'll show you how a little bit later how it looks, and how can we maintain the sinus rhythm when we already restored it after the cardioversion. We use propafenone, flecainide, but you see here from 30 to 70% 1 year recurrence rate. Sotalol from 40 to 60% 1 year recurrence rate. Low dose amiodarone. Amiodarone looks better here, better than sotalol, flecainide, quinidine, well tolerated, and the percentage of recurrences is not so big. But remember that the antiarrhythmic drugs don't prevent atrial fibrillation, they simply delay recurrences. And how looks the AV nodal modification when the ablation catheter positioned in posterior septum and removed from compact AV node? And after this, you see here, we use it in the situation we are not able to decrease the ventricular rate with the medications. And now initial heart rate is 190, and when the radiofrequency was applied, you see here the decreased heart rate. But sometimes we need to destroy the AV node And in this case, what we get, you see here, initially it was the atrial fibrillation when we destroyed with the radiofrequency ablation the atrioventricular node. You see here the asystole, but with the pacing switching with the permanent pacemaker. So, and as the result, the ventricles contract under the conduction of the permanent pacemaker, and the atria continue to fibrillate. But at last we get the situation when the heart rate became more more effective without any tachyarrhythmia. It's the newest approach. It's the schema of so-called maze procedure. It may be performed with the open surgery when the lines of ablation divides right and left atria into sections. It prevents multiple reentrant circuits, and sinus impulse conducts through circuitous course of atrial tissue to reach AV node. The efficacy of, and you see here the removal of the left atrial appendage together, right atrial appendage. It's the maze procedure with few modifications from maze 1 to maze 2, 3, 4, 5, and at last, such maze information, it is not an ultimate procedure. The percentage of success does not exceed 70, maybe sometimes 80%. The more attractive looks not so invasive without an open surgery. It's the catheter pulmonary vein isolation with non-fluoroscopic three-dimensional electroanatomical charting ablation, Carter system. It's before the pulmonary vein isolation, and it's post-pulmonary wave isolation when the lines of ablation isolate the inlet of the pulmonary veins. Not so effective procedure, I'd like to say. Maybe the progression of such approaches may give the better result. Atrial flutter circuit. So what is the main distinction between atrial fibrillation and atrial flutter? In atrial fibrillation, we meet multiple reentrant circuits. In atrial flutter, we usually see single or maybe couple of such circuits, and our task is just to make a barrier on the way of this pathological circulation of electrical impulse. And as the result, you see here how it looks on the ECG. Before, it looks like sawtooth edge, yes, and after the radiofrequency application, we got the normal sinus rhythm. Rather effective intervention. It's Wolff-Parkinson-White syndrome. Its appearance depends on the presence of so-called accessory pathway between atria and ventricles, accessory pathway which override the normal AV node. And you see here how it looks on the ECG. It looks like short P wave, and appearance of so-called delta wave, which makes such a deformation of QRS complex such an additional additional deflection of the electrical activity. So you see here, in WPW syndrome, the appearance of arrhythmias depends on the interactions between EV node conduction and accessory pathway conduction. Usually we see orthodromic reciprocating tachycardia. Atrial fibrillation, not so frequent event, and more serious is so-called antidromic reciprocating tachycardia when the excitation of ventricles goes with the direct conduction through accessory pathway from atrium to ventricles. In orthodromic, we see the reciprocating excitation of it. And incidence of sudden cardiac death is very low, practically insignificant, but we have to treat it. You see here how looks orthodromic reciprocating tachycardia in Wolff-Parkinson-White syndrome with the narrow complexes, narrow QRS complexes, but with very, very high rate of ventricular contraction. How looks antidromic reciprocating tachycardia in Wolff-Parkinson-White? It looks resembling ventricular tachycardia. In any case, when we see tachycardia with white complexes, we must to consider it like ventricular tachycardia. We have not any time to analyze it, and usually the best way is to perform electrical cardioversion for it. And very bad, very unpleasant problem like atrial fibrillation in Wolff-Parkinson-White syndrome. Fortunately, we meet it in very rare cases, but it is rare. Sure, it needs the electrical cardioversion in any case. I think we need to skip this slide because only one good treatment for WPW syndrome is catheter ablation. And we don't need to use many drugs to treat it, to prevent it. We need just catheter radiofrequency ablation. It is not a treatment procedure, it is a healing procedure because the efficacy of this intervention exceeds 95%, close to 100%. And you see here, such an intervention is performed by guidance of so-called CARTO, three-dimensional mapping system. We can compare it with GPS navigation of the tip of the catheter into the cavity of the arteria. So remember, please, the best and ultimate treatment, moreover, healing for WPW syndrome is radiofrequency catheter ablation. How it looks, you see here. The application of radiofrequency to the accessory, against the accessory pathway, and at last we got, you can compare the picture of WPW syndrome, and at last we got the sinus rhythm. Now we'll discuss premature ventricular beats. You see here monomorphic unifocal premature ventricular beats. Now monomorphic unifocal ventricular bigeminy. What means the bigeminy? Normal premature beat, normal premature beat. If we meet normal premature, it's trigeminy. normal premature beat, quadrigeminy. But in general, we name it like allorythmic pulse. So paired ventricular premature complex is here monomorphic, or better to say ventricular couplets, how they look. And at last, it's the so-called non-sustained ventricular tachycardia. We define it like three or more consecutive complexes with the duration of episode up to 30 seconds. It's non-sustained ventricular tachycardia. And at last, you see here, it's the worldwide accepted classification of premature ventricular beats by Barnett Lawn. Grade 1, rare unifocal premature ventricular beats. Grade 2, frequent unifocal premature ventricular beats. Grade 3, polyfocal premature ventricular beats extrasystoles. Grade 4, 4A and 4B. 4A, we meet premature ventricular extrasys unifocal couplets. 4B, polyfocal couplets. And at last, grade 5, so-called early premature ventricular beats and non-sustained ventricular tachycardia. But in general, we define the ventricular premature beats from grade 3, including grade 4, like high-graded ventricular premature beats. And at last, you see here monomorphic sustained ventricular tachycardia. Here is the worst situation when we meet polymorphic ventricular tachycardia. And the next stage of this problem may happen like ventricular fibrillation with some chaotic electrical activity, electrical storm, like we say. What to do in this situation? Such a problem. So, immediately perform electrical cardioversion. So is the life-saving procedure, the resuscitation procedure. Well, how to treat the ventricular arrhythmias? We can use antiarrhythmic drugs. In some cases, when the patient has the high risk of sudden cardiac death, we use implantable cardioverter defibrillators. When the ventricular life-threatening ventricular arrhythmias depend on presence of post-MI complications, including scar formation, including especially aneurysm formation, we can use surgical aneurysmectomy, subendocardial resection of this arrhythmogenic tissue, and at last catheter ablation. Not so effective, unfortunately. And it's the pharmacological approach of the management of ventricular tachycardia, ventricular fibrillation. We speak not about the management, not about the treatment. We speak about the prevention. We can use the wide spectrum of class 1 drugs, including 1A, 1B, 1C. We can use beta blockers for long-term treatment. We can use potassium channel blockades with amiodarone sotalol, and at last calcium channel blockers, not so uh, in some very selected cases. And I want to return, we started from it. In some situations when we suspect the very high risk of sudden arrhythmic cardiac death, we can implant automated implantable cardioverter defibrillator. And you see the record how it works. But by the way, it's the self-recording of this device, of this electronic box. You see here, the device recognized the ventricular tachycardia. It waits usually for 13-14 seconds, maybe it should be self-terminated, and after this it gives the electrical discharge, internal electrical discharge, no restoration here, and the second discharge, and you see here the closed sinus rhythm strip ECG. So at this point, the patient was saved from the sudden arrhythmic cardiac death. So it's the life-saving device. And you see here how it works.
Monitor every single heartbeat. If a lethal rhythm appears, the defibrillator shocks the heart back to a normal rhythm. Betty's defibrillator basically serves as a rescue squad in her chest. Collarbone. Signals from the two wires or leads that are threaded into the heart's chambers monitor every single heartbeat. If a lethal rhythm appears, the defibrillator shocks the heart back to a normal rhythm.
Well, so I see it is very obvious, clear for you how it works. But for the same purposes, you can find the automatic external defibrillators, which may be mounted into the wall, and anybody can take it to perform the prompt immediate cardioversion for a person who suddenly died. So you see here, usually such devices you can find in the big hubs, airports, and so on, in some trade centers, maybe in some entertainment centers, and so on. Is it useful? Probably yes. Probably yes, but needs some active people who can perform this life-saving procedure. Conduction abnormalities. What we see here, right bundle branch block. A rather benign problem because usually it does not lead to some significant abnormalities of the cardiac contraction. But on the other hand, the left bundle branch block, it shows the presence of organic heart pathology, and it usually leads to the deterioration of the contractility function of the heart. By the way, both right bundle branch block, left bundle branch block, these conditions have not any particular treatment. We have to treat the underlying disease. EV block. It's first degree EV block. Rhythm is regular, but PR interval is very, very long. First degree EV block, Mobitz type 1. You see here, PR interval prolonged progressively, and then except the expected complex, you see the pauser. It's rather benign condition, usually self-limited, and in this case, what we see second degree EV block, Mobitz type 2. Mobitz type 2, when PR interval is stable, but with periodical disappearance of the expected QRS complex. It is not benign condition. It usually looks like indication for permanent pacemaker implantation. And third degree AV block, It is better to say complete heart block. You see here the total independence between contractions of atria and contractions of the ventricles. How to manage it? Sure, the best way is temporary or permanent pacing. But usually we have so-called time gap between the decision making and implantation of the pacemaker. How can we support the ventricular rate at this moment? We can use atropine. We can use isoproterenol. By the way, please pay attention. Isoproterenol is the best way to increase the ventricular rate. The same we can say about dopamine, about epinephrine. Sometimes we use theophylline also to increase the heart rate. But the best approach is to provide the immediate temporary or permanent pacemaker. When pacing is strictly indicated, we can sure discuss it for a long time, but the main positions which are it's AV block second degree type Movitz 2 or complete heart block. It's obvious, I think. Margani-Adams-Stokes syndrome. Margani-Adams-Stokes syndrome. What does it mean? It means the loss of consciousness depending on the extremely significant bradycardia, depending on the complete heart block. Ensure the progressive deterioration of systemic endocoronary circulation depending on this problem. How looks the contemporary pacemaker, dual chamber with the pacing of right atrium and right ventricle? In nowadays, we can consider the implantation so-called leadless cardiac pacemaker, self-contained leadless cardiac pacemaker, which does not need any electrodes. It is implanted in the cavity of the right ventricle. And how it looks on the ECG, on the X-ray film, you see here. I think it's the future for pacing introduction. We must take into account the pacemaker nomenclature. So, by North American Society of Pacing and Electrophysiology, NASPE. So, these devices have few letters, including the first letter means chamber paced, the second letter chamber sensed, the third response of sensing, and the fourth programmability rate modulation. Sometimes we add the fifth letter, but it's the simplified nomenclature you see here. We can pace atrium, ventricle, or both dual. Chamber sensed may be atrium, ventricle, dual. Response to sensing, none, trigger, inhibition, or dual. And programmability rate modulation, simple, programmable, multi-programmable, communicating, R. So the former devices had such a nomenclature like for ventricular pacing, V, V, I. It means ventricle paced, ventricle sensed, and the type of the reaction inhibition of impulse when the device recognized the self-activity. And the newest was rate modulation. Imagine, we need to provide the rate of contractions according to the patient's activity. For example, Patient sleeps 60 beats per minute. Patient walks 70, 80, runs up to 100. Yes, but in our so such devices had the nomenclature like VVIR. But the newest devices nowadays we implant practically dual chamber devices. They have dual, dual rate modulation, sometimes communication, multi-programmable. So it sounds like DDDR. It's the best way. And how looks atrial pacing? You see here, so-called spike with the excitation of atrium, then ventricular contraction. How looks ventricular pacing? Spike, I think what is spike? Spike is the electrical impulse which we see on the ECG like such a vertical electrical signal. Then ventricle excitation spike, ventricular excitation, and so on. And dual chamber pacing. Dual chamber, atrium, ventricle, atrium, ventricle. Is the best way to do. And at last, I'd like to say you don't have to know everything to be a great doctor. You just have to think. So I want to say you as usual, take care and goodbye. Well, so if you have some questions, you can ask, but you see just few persons who now watches this presentation. So let me finish with it. Once more, goodbye, take care.